Welcome back to Oncology Data Advisor. My name is Rahul Banerjee, and I'm one of the board members of Oncology Data Advisor. I'm also an assistant professor of medicine at the Hutchinson Cancer Center in Seattle. Today, it's my pleasure to be joined by Dr. Yi. Dr. Andrew Yi is a clinical director for multiple myeloma at the Massachusetts General Hospital in Boston. He's also an assistant professor of medicine at Harvard Medical School. He specializes in multiple myeloma, and both of us were there at the International Myeloma Society meeting last 2 months ago in September in Greece, where the CANOVA study of Venetoclax and dexamethasone was published. Dr. Yi, pleasure to have you joining us back on the program today.
Hey, Rahul, thanks for having us, and it's great to always be talking on myeloma, especially on a late Friday afternoon.
Yes, indeed.
Always fun. And and I think the key disclosure is we were actually talking about this trial before Athens, and I think before Athens, before the CANOVA data was presented, I think all of us were really excited to hear this data, and all of us had assumed it was going to be a slam dunk in favor of the Venetoclax arm. And when the data was presented, that was a little bit of an eye opener. It did put some pause in our how we think about the efficacy in TLM14 as well as clinical trial design.
I completely agreed. Yeah, this was going to be as part of Blood Cancer Awareness Month. We were talking about precision medicine and myeloma. Are we there yet? And we talked this big game, all this, cool data that we'll
Yes.
talk about from the Bellini study. And then, I don't know if you or any listeners are fans of Loki or the Marvel Cinematic Universe, if we had to time slip backwards because Canova changed everything, as we'll talk
Right.
about. And now we're back to re-recording our podcast
We
with the
re-recorded just to make it so it's just a disclosure.
we were both in Athens that day, and I feel like there was just like a hush came over this auditorium of hundreds of people in this ancient opera house from Greece when the study was presented. So let's get into it then. So, as we've set this big stage about how big the study was a surprise to us, let's talk about T1114. So what does it refer to in myeloma? When you hear that someone's myeloma cells on their bone marrow biopsy has translocation 1114, what do you think about?
Right. So we think about when we think about multiple myeloma, we think about some characteristics, molecular subtypes, and IgH translocations is one of the characteristic subtypes. About half of myeloma patients will have an IgH translocation, and this includes translocation 1114, 1416, et cetera, et cetera. And these translocations are felt to be there from the beginning. These are probably presumably involved in one of the early stages of the transition from being a benign plasma cell to a myeloma cell. So in translocation 1114, you have the IgH locus connected to chromosome 11, which has, which we think of as cyclin D1.
Mm-hmm.
And about 15% of patients roughly will have translocation 1114. And the other interesting thing about, even though it's cyclin D1, it's not necessarily related to cyclin D1 per se in and of itself. And it has to do with the BCL2 pathways, et cetera. And a couple other things to point out would be, number one is that translocation 1114 really requires FISH to detect, right?
Exactly.
You can't, just do conventional cytogenetics to pick up translocation 1114. This applies to other translocations like 414, for example. And it really emphasizes that if you have a clinical concern for myeloma, that clinicians should be doing a myeloma specific FISH panel so that you can pick up these specific translocations. And the other thing about translocation 1114 that's interesting is that it can be associated with certain phenotypes like non-secretory disease, for example, or it tends to be more prevalent in conditions like AL amyloidosis or plasma cell leukemia. So those are all, kind of unique clinical characteristics with translocation 1114.
Absolutely.
And then this would probably segue into our discussion of Venetoclax. I think another interesting feature about translocation 1114 is that sensitivity to inhibition of BCL2.
Absolutely so. Yeah, I think it's an excellent segue. I think going back to FISH, I think most physicians, right, they check FISH at diagnosis, standard risk versus high risk. This is standard risk, and then people think it doesn't really matter after. Whereas after that, this is a scenario where in the relapsed refractory setting, if you know someone has 1114, it might actually change your management. So
Exactly.
maybe we can get into it with the Bellini study because that's what kind of first paved the path for this,
Right.
Paradigm. So maybe can you tell us a bit more about that study?
Right. Well, I think even before Bellini, I think there was the appreciation that that cell lines with translocation 1114 were very sensitive to venetoclax, and then
Very
that led
true.
to some initial studies in people whereas a single agent they were seeing response rates of 40%, and then that paved the path for Bellini, which was a phase 3 randomized study that compared the addition of venetoclax to bortezomib and dexamethasone versus bortezomib and dexamethasone in relapsed and refractory patients. And, I think and this was across all patients, irrespective of translocations. And I think the study was moving along forward, but then there was a Dear Investigator letter in 2019 that showed that, that the road was getting kind of bumpier because there was a concern for increased mortality with the venetoclax arm. So then that led to a clinical hold. And, so this kind of speaks to the importance of doing randomized studies, right? We kind of assume that this drug is going to work great, but then you really need a phase 3 study to really see what the difference is. You can't just rely on single arm studies. And it turns out that yes, across all comers, there was, a concern for increased mortality, and that perhaps could relate to infection. But
absolutely,
in the small subset of patients who had translocation 1114, you saw a whopping benefit in terms of efficacy. I think a hazard ratio of 0.12, and then the overall survival was preserved, maintained. And so suggesting that because the degree of efficacy, it sort of overshadows any potential decrement related to infection. So, but I think, that was just a tiny number of patients, like maybe 20 patients, like a small proportion. And the Bellini stuff, but even though, based on those findings, it did motivate using venetoclax, off-label, especially, in patients who've exhausted all options. I think having this as an option was helpful. So I think this motivated the CANOVA study, because you need a confirmatory study, right? Again, it was just an assumption, again, post-hoc analysis. And, there are examples of where, post-hoc analyses have led people down, paths, unintended paths. And the CANOVA study is meant to be a definitive study to really answer the question, can we use venetoclax in translocation 1114?
Very, very well stated. Yeah, I remember that letter just as you do. And I joke to, readers of the podcast, you see the link to it. You'll see if you look at the letter, the FDA was so rushed to unpave that road that you actually can see little red squiggles in the Kaplan-Meier curve where there were the spell check hadn't been turned on. They took a screenshot so quickly to get the data out here. But you're right. I think the idea is that, as you're alluding to, like venetoclax does have risks in these patients, like infections, and you're like, who are these patients for where the benefits dramatically outweigh the risks? And so Bellini couldn't directly answer that question because it wasn't powered or it wasn't designed to. So let's pivot to CANOVA. So how was CANOVA designed with that in mind?
So CANOVA is just focused on patients with translocation 1114, and it was a randomized study that compared venetoclax dex versus a standard control of pomalidomide dex, which the audience has heard before because there are 2 other randomized studies that use pomalidomide and dexamethasone. And it was a standard pomalidomide dex, 4 milligrams of pom, 40 milligrams of dex. And I think the thing to appreciate with CANOVA is that they used venetoclax 800 milligrams with 800 milligrams of venetoclax with dex 40 milligrams. And they randomized about 130 patients to each arm. And, we're thinking about this further. We were waiting for CANOVA for a long time, right?
Many years.
A long
Indeed.
time. And I was thinking, I would have thought going in this based on the Bellini, based on the hazard, this was going to be a slam dunk. It's going to be, it's going to blow it out of the park. And that was my initial prior. But then I'm thinking, God, it's been taking such a long time to read out. And then, of course, some of it had to do with COVID that was affecting the accrual. But generally speaking, if something works really well, you generally hear about it reaches its endpoint pretty quickly. And then usually there's a press release. And I'm just thinking about, for example, some of those daratumumab based studies. There'll be, there's a daratumumab study for newly diagnosed or relapsed, they'd accrue, and then there'd be a press release pretty quickly. And then like, for example, I think about, the daratumumab Lendex, how that study started after elotuzumab and started after ixazomib, but they presented their data before because of the hazard ratio was so effective. So anyway, my assumption was, the CANOVA's gonna have a great hazard ratio, but the longer and longer, I was like, getting a little bit concerned. But I still was really hopeful.
Well, especially because as we talked about the first iteration of this podcast, it was kind of precision medicine against, generic medicine. This is not cookie cutter, specifically
Exactly.
precision pills that block 1114. And I think, Bellini was a triplet versus doublet. This is a doublet to doublet trial, right? So they
Exactly.
went
A little bit, yes, a little bit
little
more,
more
but it's
ambitious.
focused. It's not all comers. It didn't meet its primary endpoint. The PFS was not statistically significant. I'm referring to my notes. There was like 9.9 versus 5.8 months. The hazard ratio was 0.823, and the p-value was 0.237. So it didn't meet its primary endpoint. So initially I thought 0.823. God, that's not even that dramatic. And it's not the 0.12 that we saw with in that little tiny subset of the Bellini. And I think, in terms of, of course, trying to unpack, why is this the case? How could this study, how did it play out this way? And so one of the explanations was that, this has to do with how we do think about IMWG confirmed responses, how we define, progression events. And for IMWG, you have to have a confirmed progression event, as in you can have an M spike go from 0.5 to 1, but it has to be confirmed on the subsequent blood test to say this is confirmed progression. And what was going on in, one of the issues was that patients were switching to a new line of therapy even before it's formally confirmed as progression. And as a result, those events were censored. Now, if you reanalyze the data post hoc and say, okay, anybody that changed to a new line of therapy, we're going to call progression. Well, then you do see it was the hazard ratio of 0.651, and the p-value was 0.003. So that was the post hoc analysis. Another interesting, so that was one aspect of it. And the second aspect of it was the overall survival. There was that concern about worse overall survival.
Correct.
Actually, the overall survival looked improved, right? The hazard ratio was 0.697. Now I should, just normally I tend to be really enthusiastic about stuff when we're talking about stuff, right? Because it's easily for me to
I'm the same way. Yes, indeed.
To get, once we get going. But I think something to point out is that there was some concerns with infection. So there were 7 treatment-related adverse event deaths that were attributed to Venetoclax. So that's just something to be mindful of as we're using this drug. Now, how do I think about that in clinical practice? Like, what does this mean?
Yeah.
I think the dosing of Venetoclax, it's 800 milligrams, and I think in clinical practice, I think 400 or even 200 milligrams can work very well. And I'm not sure what do you the dosing, and a part of me wonders, lower dose, maybe that risk of infection would be much less, as well as also the side effects, right? Because I think some of the other side effects are GI related, diarrhea for example. And I think also Venetoclax comes to 100 milligram pill, 100 milligrams, and it's also just from convenience, it's also easier.
Agreed. So we'll come back to at the end. I'll come back to the how we approach it now in terms of dosing in the real world setting, and not even retrospectively with our own patients today. But yeah, I mean, I think this comes. You're right. I think one of the biggest takeaways from the study for me was not really anything to do with venetoclax or pomalidomide, but all of a sudden clinical trial design. You're right. Like, how do you define censoring? Is it informative or non-informative? Normally, it's really someone coming off study early should really be completely random, non-informative. And here, clearly, patients who are on Pomdex were being taken off at higher rates and moving to something different and weren't really counting towards this PFS advantage.
One thing, Rahul, to point out is also, you wonder if they had put more patients on too. Like maybe if they had put like maybe 50 or 100, I don't know the statistics behind this, but maybe if they had more patients, maybe the hazard ratio would have, they would have been statistically significant. So,
Agreed. It just, but like you said, I think the important part, as you alluded to, is like there have been other studies with Pom and Dex where you see better, deeper responses, but increased mortality. Here, the overall survival, as you're alluding to, does seem to not statistically significant, does seem to suggest that this Vendex is real. And what we saw was more a function of just the quirks of clinical trial design and how the endpoint was defined more than anything else.
Or just maybe you need to have more patients. But of course, with these, these trials are cumbersome. They require resources and and money, etc. In terms of how you use the dosing of ven. I think myeloma, in these studies with ven and myeloma, all the patients started at the assigned dose from day one. There's no
Ramp up.
loading dose. There's not the concern for tumor lysis syndrome that you would see with chronic lymphocytic leukemia. So all these patients are started full dose from day one. But I think in practice, in some patients that do start at 200, some patients that start at 400. And the other part too is, the CANOVA was the doublet, but I think we should also think about triplet combinations. So I'm just thinking, for example, somebody who's Maya, translocation 1114, Dara, Rev, and they're progressing. I think that would be a perfect opportunity to, they never seen a proteasome inhibitor, and they have translocation 1114. I even with the results of the CANOVA study not being positive, I'd feel totally comfortable using Venetoclax, bortezomib, dex in that patient population.
Agreed. I mean, yeah, even Venetoclax with Velcade, what the Bellini did, you have to wonder if CANOVA was just Bellini cloned 1114, things would have been different.
Exactly. They're just like repeat Bellini, then it could have been a slam dunk with a tiny number of patients.
So maybe we can pivot to that now that we've done this time slip. So we basically, for the audience listening, we did this entire podcast, so excited about CANOVA coming out, and then it changed at the last second. We're like, let's time slip backwards and start over again. There were some other, research abstracts presented at IMS with Venetoclax 1114 that didn't involve CANOVA. Can you talk a little bit about those and whether you would kind of lean towards those instead in real world practice today?
Right. So there are other randomized studies that were presented as well. Like, so Dr. Kaufman presented two studies. One looked at daratumumab, Venetoclax index, and the other one looked at carfilzomib with Venetoclax index. So you have two other randomized studies, but granted, these studies were relatively small. Like, each of these arms had around 15 to 20 patients, but consistently you saw that there was a numerically significant improvement in, with the addition of Venetoclax. So I'm just thinking of, Venetoclax carfilzomib index, is kind of a doubling of the, PFS. It was like 32 versus 14 months when you added Venetoclax to carfilzomib index. And, then your next question was, it statistically significant? I think it didn't show statistical significance because I think the numbers were so small that the numbers are so small. So I think, in my mind, I think these are just more proof of concept, just extension that the Venetoclax can add significant benefit in translocation 1114, and the choice of partner. It just means that you have just more additional opportunities to partner with Venetoclax.
Absolutely so. Yeah, and it's interesting. One of Dr. Kaufman's abstracts, right, John's work had, I think, Ven 400 and Ven 800, and you can see that 400 probably worked as well. Maybe, again, not big enough to tell for sure, but non-inferior, so to speak, in terms of maybe fewer toxicities and working just as well.
Right.
So then maybe I'll close by asking you, so now that we've time slipped all over the place and we're in our current multiverse, now in our sacred timeline, we are where we are now. How do you use Venetoclax for your patient who comes in tomorrow in clinic? 1114, let's say 2 prior lines that say, how would you approach Venetoclax or not approach Venetoclax there?
No, I think the CANOVA doesn't change my usage of Venetoclax. I'm going to continue using it the same way. I think, if anything else, the data from Athens, Dr. Kaufman's data kind of further reinforces usage of Venetoclax, especially in a 3-drug combination. So I think, if I saw a patient who has translocation 1114 and who hasn't, and is that would be a relapse disease, I think that would be a perfectly fine opportunity to use Venetoclax. Sometimes I do use it as a doublet, with dexamethasone, and sometimes I use it as a triplet. And then I should acknowledge that that there are other trials looking at BCL2 inhibition. So BeiGene, for example, just disclosure, we're involved in the clinical trial using BeiGene's sonrotoclax, which is another BCL2 inhibitor. It has some characteristics where it's like more potent than Venetoclax. And so I think there'll be other opportunities for other clinical trials to look at BCL2 inhibition to kind of further round out where BCL2 inhibition plays in myeloma care.
Absolutely so. Well, great. Well, I'm looking forward to the next iteration of this talk next year, hopefully
Of
with
course.
fewer surprises, and we can do the podcast on the first time around, not the second time
Exactly.
around. So with that in mind, thank you again, Andrew. Thanks again, Dr. Yi, for your time and expertise on this matter. And for everyone who's listening, thank you for humoring me and my multiverse, Marvel Cinematic Universe references. And thank you all for your time. Have a good day.
And thank you, Rahul. Thank you. Appreciate it.
Mhm.